So, one 65 years old lady, earlier patient was more or less fit. He is having a history of asthma and taking inhalers for since long time. Recently, when he was going to toilet, slipped and has a very minor fall. After that, he is having terrible mid-back pain. Patient is unable to stand. Patient is unable to sit for longer time. Only lying down relieves the pain. Pain is terrible. Even patient cannot turn on bed. So this is the history. What is the provisional diagnosis? Compression fracture. What are the differential diagnosis? Myofascial pain. Very good. Think of mid-back pain at this age. What are the other causes of the mid-back pain? Facet joint. Facet and myofascial, these are the two most common cause of mid-back pain. So this should be coming in the differential diagnosis, and even in the compression fracture, these two components might be additional component with it. Means many patients who are having the compression fractures, they also might be having some myofascial component, and they also might be having some pain coming from the facet joints. So what are the investigations you will suggest in this patient? Interspinous ligament injury is also a possibility. You are right. Interspinous and supraspinous ligament injury. Prolapse disc, will it come as a differential diagnosis? Not really. The two reasons. Prolapse disc after 60s is less common because disc gets dehydrated, and second thing, patient is having only the mid back pain. There is no radiations, there is no leg pains. But interspinous and supraspinous ligament is a very important differential diagnosis. And another very important thing is patient pain started suddenly after some trivial trauma. So that is also we have to recall. This is not a case of chronic pain. This is a patient of acute pain. So what are the investigations you should do?
Starting from baseline investigation. We have to look for
Baseline investigations like
CBC,
SR,
ESR, CRC, blood sugar level, serum vitamin D level also. Image and radiology investigation, X-ray,
X-ray,
AP and lateral.
AP and lateral.
And if there is any finding.
Okay, the X-ray is showing that there is a compression fracture, OH compression fracture, anterior OH compression fracture at D12. Okay, so now what further, or I might have included that history in the history sheet itself. That patient had an X-ray and showing there is a OH compression fracture at the level of D12. So how you are going to, what are the other investigations you are planning to do? Terrible pain, fracture, sudden onset, acute onset. One is obviously MRI. Why MRI is needed?
MRI to look for it is active.
MRI to look for the vertebral body edema. If there is a edema in the vertebral body, that indicates it's a recent fracture. If there is no edema, it indicates an old fracture. It can also happen that this patient was having an old fracture, and recently and patient was not knowing it. It is quite possible. And recently after the fall, there is some myofascial pain. This is also a possibility, one case scenario. So you should have an MRI to understand whether there is the edema, vertebral body edema is there. And another thing to look for in the which we cannot understand from the X-ray itself is how much the spinal canal is getting compromised, whether there is any fracture of the posterior cortex and whether the spinal canal is compromised or not. That is another reason why I should have an MRI. Then what else investigation should be done? This patient, one clue is there that this patient is asthmatic and this patient is taking inhalations for since long. So what is the possibilities here? Osteoporosis. So osteoporosis is more common if somebody is taking corticosteroid for a long time. So what are the investigations should you do then? One of them is DEXA scan. So what is the normal DEXA score and what is the osteopenia, what is the osteoporosis? What is less than 2.5? What? A, B, C, D, what?
Standard deviation.
What? T-score, you tell that. T-score should be
It is less than
within one standard deviation. That means +1 to -1 is normal. Then
osteopenia.
1 standard deviation to 2.5 standard deviation is your osteopenia. And osteoporosis is less than -2.5 standard deviation is your osteoporosis. So DEXA scan is the gold standard for diagnosing osteoporosis. Is there a role of serum calcium in diagnosing the osteoporosis? So serum calcium don't have any role in making a diagnosis of osteoporosis because serum calcium is a very important ion in our body. It is essential for neural transmission, muscle contraction, different enzymatic actions, everywhere it is needed. So body maintains it by hook or by crook. If there is any fall in the serum calcium level, immediately it will be mobilized from the bone. Bone is basically a calcium bank, and that calcium bank should have adequate balance, bank balance in our early adulthood. After early adulthood, so there is only one way channel. It can come out of the bank, but nothing will go inside the bank. So more and more calcium you are giving after somebody is adult, the calcium will be lost in the feces or excreted in the urine. Nothing will go inside the bone, with some exceptions. What are the exceptions? If there is a fracture, then it will be deposited in the bone for the fracture remodeling. If somebody is doing exercises causes bone there inside the calcium inside the bone. And two other. One is some of the drugs. What are the drugs? Earlier drug was anabolic steroids, durabolin and decadurabolin. Nowadays those are not used. Nowadays is your teriparatide. And apart from that, osteoblastic tumors. That also causes deposition of calcium in the bone. So otherwise, if you are giving lots of tons and tons of calcium and vitamin D, everything will be excreted. It will not be deposited in the bone once we are adult. Till early adulthood, the calcium can be deposited. The osteoblastic activities might be there. Okay, so here the serum calcium still should be done. Why it should be done? Because one of the important differential diagnosis of the spinal fracture is whether it is what kind of fracture is it? Is it an osteoporotic fracture? Or very important differential diagnosis at the elderly is whether it is a multiple myeloma or other secondaries that is common at this age. So you have to rule out the multiple myeloma and secondaries. How to rule out that? One of the way is your serum calcium. What will happen to the serum calcium if it is multiple myeloma or other secondaries? The serum calcium will be increased. So you have to do some other investigations also to rule out the multiple myeloma. Multiple myeloma is quite common, and multiple myeloma can present like this. Sudden severe excruciating low back pain or mid back pain, more common in male though, here it is female, but still it can be in the female as well, and pain is not responding and you are having an X-ray and you will see that there is some fracture. So this can be a presentation. Very recently I have seen one such patient. Patient was approximately 45, 50 years of age, and he was basically working in Mumbai, and he was having very severe pain. So he has visited one of our fellow from Mumbai, and patient was having the osteoporotic fracture on X-ray. He was telling that, okay, please go back to your Kolkata because you are originally from Kolkata and you are having the fracture, so sir will do vertebroplasty. So go back. So he came here and we did investigation, and ultimately it came to multiple myeloma. So this is quite common at this age. So multiple myeloma should be a very important differential diagnosis whenever we are seeing a patient of vertebral compression fracture. And for that, what are the basic investigations to rule out? One of them is your serum calcium. What are the others? So these are the routine investigations whenever you are getting a spine fractures. One is your DEXA scan, other is your serum calcium. What are the other things? Liver function test. Why it is important? Because in multiple myeloma, the globulin level increases. So in the liver function, if your total serum protein is increased, so you should be cautious. And apart from that, you may or may not add another is your M band protein, myeloma band protein. So that there will be a spike of the myeloma band protein. But even if you are not asking for the multiple myeloma M band protein, you can at least have these two which will be giving you some clues. One is your serum calcium level and second one is your serum protein level, particularly the globulin level and albumin globulin ratio. So that will be giving you the clue whether it is a multiple myeloma or not. So M band proteinuria is important for the heavy chain multiple myeloma. Multiple myeloma is, there are two types. One is heavy chain, another is light chain. So multiple myeloma, the one way the LFT is important because the globulin will be increasing in whether it is a light chain or whether it is the heavy chain, but it may not be always reflected in the M band. So ideally when you are getting, so LFT, serum calcium and M band, you should be always doing it. Particularly if the patient pain is very severe, sudden onset, acute onset, you should be doing these tests. Okay, so apart from that, what else tests should you do? Some of the tests should be done keeping in mind that I might be going for the interventions. So what are those tests that they are talking? Coagulation profile. Coagulation profile should also be checked. It's not related to the diagnosis, but it is related with the intervention. Okay, patient's pain was not relieved with the conservative management. So what should you do? Bed rest. Because lying down is relieving the pain. So should you ask for the bed rest for 1 month? Or another very earlier treatment was giving a whole body jacket cast so that there is no movement. Nowadays it is obsolete. It is not done. Earlier it was done. Bed rest was also one of the earlier treatment. Now it is not done. What is the problem with the bed rest? So long list. But what is very important in this context? Osteoporosis increases severely with the bed rest. So what happens if it is an osteoporotic fracture and if we are giving bed rest for 1 month, so by that time this fracture might be healing, but osteoporosis will be increased so much that it will not be taking the body's load. So by standing or sitting itself, the other vertebra will start collapsing. And you will be getting this kind of patient that there is a started with one fracture and then multiple level fracture, and ultimately patient is becoming kyphotic because of the lots of fracture in the almost all thoracic bed. And this is quite common in asthma COPD patients who are taking steroid inhalations. So bed rest is not the answer. So one is you have to make this patient mobile as early as possible. How? One is using analgesics. So you should be using opioids also in these patients to give a good pain relief. And if still pain relief is not significant, then what should you do? Vertebroplasty. So now you tell how to prepare the patient for the vertebroplasty. So two steps. One is the preparation on the day of the procedure and preparations before the procedure. So what are the steps before the procedure? Investigations. Not only this patient is also asthmatic. So this procedure to be done under the prone position. So you have to make sure that patient will be able to lie down prone for a long period. So proper control of the asthma is also very important.
Should we do pulmonary function test for the patient?
We should be ideally taking clearance from a pulmonologist, and you should be, another very important thing is, I remember I have treated this kind of patients earlier also, and it is very difficult. Patient cannot, majority of the patient lying down prone for a long time is very difficult for them. So you have to be very sure that this patient can lie down for prone position for the longer time. That means adequate control of the COPD or asthma is mandatory before doing this procedure. Because vertebroplasty is a procedure which should be ideally done under local anesthesia, sedation, not under the general anesthesia. Why? Majority of the interventional procedures should be done under the sedations, not under the general anesthesia. Because if your needle is inadvertently going to the nerve root or other areas, that is a very important warning signal which will be prohibiting you to do some major complications. So that is the reason majority of the interventional procedures, almost all interventional procedures should be done under sedation or just local anesthetic, no general anesthesia. Okay? So you have to make sure that this patient who is having the COPD or asthma, that patient can lie down for the longer time. So preoperative preparation means all those things. Adequate control of the COPD or asthma, then your routine blood investigations to rule out any infections, blood sugar level to see that the diabetes is not there or diabetes is well controlled, and coagulation profile is normal. So these are the things you have to make sure before procedure. Then on the day of the procedure, nil per mouth for at least 4 to 6 hours. Then one IV line, pre-op antibiotic. This is an invasive procedure, so here antibiotic is recommended. Then vital parameters monitoring. So remember all these four, don't miss. What are these steps? One is nil per mouth. This is true, this is almost for almost every procedures, and don't miss any of these procedures. How to prepare your patient, always this question will be asked. So whenever this question will be asked, you just tell that the preparation on the day of the procedures and preparation before that. So preparation on the day of the procedure is nil per mouth, securing IV line, your vital parameter monitoring. And before that, all the blood investigations, which includes the routine blood, coagulation profile, blood sugar level. And based on the other individual comorbidities, you have to control that also. Like somebody is hypertensive, definitely that will be increasing the increased chances of bleeding. So you have to control the hypertension as well. So depending on the other comorbidities, you have to take care of that. Like here, the comorbidity is your asthma. So you have to take care of the asthma so that the patient can lie down for the longer period. Okay, so now what are the procedural steps? Patient should be taken in prone position. Hmm? Most of the time, we put a pillow under the abdomen to correct the lumbar lordosis, isn't it? Should you also put a pillow here? Why not?
Sir, respiratory.
Okay, suppose the patient's respiratory is well controlled, no problem there. Will you still put a pillow to correct the lumbar lordosis?
It will have
Okay, I'm giving you the another question. Suppose it is in the lumbar area. Suppose it is in the lumbar area, L3 or L4. So there is already lordosis. Should you put a pillow to correct the lordosis? So you can understand from my question that its answer should be no. But what is the rationale? Why? So normally there is a wedge compression. For the how many columns are there in the spine? This is a very basic thing. 3. What are those 3? Anterior. How much is anterior? Anterior 2/3. Then that is anterior column. Anterior 2/3 of the vertebral body and anterior 2/3 of the disc. Middle column. Posterior 1/3 of the disc, posterior 1/3 of the vertebral body and posterior longitudinal ligament. And posterior column is everything posterior to posterior longitudinal ligament is your posterior column. So anterior fracture, wedge fracture, is the indication for the vertebroplasty. Middle column fracture is also known as burst fracture. Middle column or burst fracture can be 2 types. One is stable, one is unstable. When it is called stable, middle column fracture, only middle column fracture is not possible. It has to be associated with either anterior or posterior column. So when the middle column fracture is associated with the anterior column fracture, it is known as stable. When the middle column is associated with the posterior column fracture, then it is known as unstable. Why? Because the stability of the spine is because of the ligamental structures. So all those ligaments are there in the posterior column, like interspinous, supraspinous, ligamentum flavum. All these ligamental structures give the stability. So if there is a fracture of these ligamental structures, the spine will be unstable. And this is very risky here. The surgical intervention is needed. So if it is a burst fracture and stable burst fracture without neuro deficit, the vertebroplasty can be done. Can be done. Burst fracture is a relative contraindication. Burst fracture means it is the middle column, that means posterior cortex is fractured. So it is a relative contraindication. But if it is a stable one, then you might consider it, if you are that expert. Otherwise, the indication of the vertebroplasty is anterior column fracture. Okay, this is also known as wedge fracture. Okay, so come back what we were discussing. That here we try to extend the spine. Why? Because anterior column is fractured, and if you are extending it, what will happen? The collapse part will be little bit of taken away. It's so that if your patient is having the flexed, spine is flexed, then the compression will be further. Okay? So here what is more important, that you have to bring your pedicle, because most of the times we do the transpedicular approach. There are basically 2 types of vertebroplasty. One is transpedicular, one is extrapedicular. Transpedicular means that you are going through and through the pedicle and you are trying to go at the center of the fracture. What is the extrapedicular approach? Extrapedicular approach means you are going away from the pedicle and going to the center. So in which areas extrapedicular should be done? At the thoracic area. Why? Who can tell this?
Because of the angle of the pedicle.
Angle of the pedicle. Very good. Only with that I couldn't understand anything. You have to explain it more.
In lumbar area, the pedicles are more oblique, so middle entry can be such
So?
that
Oh. Okay, so shape of the vertebral body at the thoracic vertebra is like this. So, if you are putting your needle through the pedicle, what will happen? You will be reaching and depositing cement here. Okay, chances of going inside the vertebral body is less, and as you told right, the pedicles are almost vertical, so that is the reason why chances of going there is less. Whereas in the lumbar area, it is much more oval like this. Pedicles are like that. So here, if you are going through the pedicle, you will be going at the closer to the center of the vertebral body. So here what you have to do, you have to come extrapedicular from here or here. You cannot come through the pedicle. Right? What is the problem of doing an extrapedicular approach? If you are going through the pedicle, what is the advantage? That if the cement is leaking back, it will be remaining within the bone. So chances of leakage into the nearby neural structures will be less if it is transpedicular. That means transpedicular is safer than the extrapedicular approach. Extrapedicular, you are going outside the pedicle, so cement leakage and going into the neural foramen, chances will be increasing. Okay? But for the upper thoracic, where the shape of the vertebral body is almost triangular, so there you cannot go inside unless you are doing transpedicular. So basically above T6 or T4, upper thoracic, first 4 or 5 or 6 vertebral body are like that. So there you should be preferring transpedicular approach. So first is your patient should be okay, another things, let me try to draw. So suppose this is the waist structure. So this is, if you are extending, this is anterior, and this is posterior. If you are extending it and if there is a cleft, what will happen? So you can separate this little bit, not much but little bit. And this is particularly possible if the fracture is cleft non-healing fracture. Cleft fracture means there is a gas shadow within the vertebral body. So basically the two flaps are separate. So when you are extending it, it will be separated. So that will be giving the better feeling of the fracture site. And if you are flexing it like this, then what will happen? It will be further collapsed. So that is the reason why you should not do a flexion or put a pillow. Put a pillow means what? You are basically flexing the spine. So here we should not do the flexion of the spine. Here we should even try to extend it. You can put pillow one over the chest, another over the thighs to extend it further, or just no need of putting any pillows. So now patient is prone, then what should you do? If you are doing at the level of the L2 to elbow as taken, so normally in the T to L we go transpedicular approach through the pedicle. So what you have to do? You have to bring the pedicle at the center of the vertebral body. So for that you may need a little bit of craniocaudal tilt and ipsilateral oblique. How much ipsilateral oblique? Till you see the transverse diameter of the vertebral body, pedicle maximum. So again, let me try to draw it. Suppose this is your pedicle. Pedicle is like a cylinder. So when the serum beam is perpendicular to it, you will be seeing the pedicle very nicely like this. But suppose serum beam is coming like that, then how it will see? It will be seen as an oval. If the serum beam is coming from here, again it will be seen as an oval. It will not be like this. So when your this thing is your, suppose this is pedicle. Pedicle is not vertical at the level of the lumbar area, isn't it? It is little bit of tilted. So now first you are taking AP. So how will you see? You will be seeing like an oval, because it is not in line, it is perpendicular. So you will be seeing at an oval, not a round. Transverse diameter will be less. So now you are gradually making it oblique. So gradually what will happen? Your transverse diameter will be gradually increasing. Then if you are making it more oblique, then what will happen? Again the transverse diameter will be gradually decreasing. Understood what I am trying to tell it here? That if you are AP, then your transverse diameter is less. It will be looking like an oval. Making it oblique, ipsilateral oblique, gradually transverse diameter will be increasing. Now if you are making it more oblique, then again transverse diameter will be decreasing. So you have to understand, when the pedicle's transverse diameter is maximum, that much oblique should be done. That means now your shear beam is going exactly in line with the pedicle. When your transverse diameter of the pedicle is in best maximum, that much oblique you do. Okay, and then you go place your needle upper and outer quadrant of the pedicle. Why upper and outer quadrant of the pedicle? Not the inner part of the pedicle, that is very obvious. Because if you are going to inner pedicle, if your needle is little bit going more inside, then you are going to break the pedicle and going into the spinal canal. Pedicles are basically the lateral boundary of the spinal canal. So if you are breaking the pedicle, so that is the reason why your needle should be outer part. But why? That means if this is pedicle, you should be dividing into 4, and this quadrant will be your needle entry point. Not here, not here, not here. So not here and not here, it is easily understandable. But why not here? Why not the lower part? Because suppose this is a pedicle, this is a vertebral body. So I have taken this section, coronal section. So now nerve root will be coming like this. Suppose this is another. So neural foramen is from this much to this much. So nerve root occupies the upper part. So nerve root and dorsal root ganglion lies here. So if nerve root is going like that, this is the 4th quadrant. So which part will be your choice? If you are here, if you are again going little bit down, you are very close to your nerve root and dorsal root ganglion. If you are here, then nerve root is Above nerve root is going much above here. Understood? Next nerve root is going there, it will be here. So if you are in the upper part, then you are away from the nerve root. Right? So that is the reason why your needle should be in the upper and outer quadrant, and you go by the tunnel vision and frequently check by the AP view and the lateral view. So when you have entered into the vertebral cortex on the lateral view, if you see that your needle has crossed the vertebral body, then you can cross the medial border of the pedicle. But before that, you must not cross the medial border of the pedicle. Understood what I am trying to tell? Okay, let me explain it to you. So this is the spinal canal. So you have started from here, and your needle should be in the tunnel vision, but the AP view, your needle should never crossing this line, because then you are going into the spinal canal. Okay, but you can cross this once your needle is inside the vertebral body. Okay, that means you have to frequently check by the lateral view. Suppose this is lateral view. So if your needle has entered here, and then you can cross this mid lateral. This is the AP view. You have to check by the lateral oblique view. When you are going by the oblique, and when you are taking by the AP view, you will see the needle is coming closer to here. In the oblique, it will be at the lateral, within the pedicle. But in the AP view, your needle might be coming closer to the anterior medial border. But you must not cross the medial border until you have entered into the cortex. Once you have entered the cortex, then you can cross the medial border. That means you are already in the vertebral body. Okay? So at this point, you should be advancing the needle further till you are into the anterior. Needle should be advanced further till here. If you are making it at 4, 3, some says 4, your needle must be entering here, and then only you should start injecting it. If your cement leaks here, immediately stop it. Okay? Posterior 1/3 or 1/4 area, the cement must not come. Why? Again, try to understand another very important concept. So, our vertebral body shape is like that, not completely round. So, when you are seeing this in the lateral view, so if your cement is coming here, in the lateral view, you might be still thinking that I am within the vertebral body. Understood? Because we are not doing a CT scan. It is not in the 3D image, it is the 2D image. So the 2D image, suppose your cement has leaked, you are injecting cement here, and you have taken a lateral view. So what will you see in the lateral view? Lateral view, posterior border will be here, anterior border will be here. So if your cement is within the vertebral body, still you might be thinking that my cement is within the vertebral body. Clear? And that is the reason that on the lateral view, as I told you earlier, if you are making the 3, the cement should never be coming in this area. That is dangerous area because vertebral body is like this. The lateral view, what we are seeing, this is not the real one. It might be this part, but this part, middle part, might be in this area, in the lateral view. So if the cement has leaked here, your cement might have leaked coming here. So that is the reason why the cement should never be allowed to come in the posterior 1/3 or posterior 1/4. Okay? So now you should be gradually filling it. How much volume to be given? Normally something around 4 to 5 cc. Don't inject much because it might be coming back. And you should start injecting once your needle is there in the right position. You check by the different angle, and then finally whether dye to be given or not. Majority don't prefer to give dye. Why? Because dye might be obscuring your needle tip and you may not be able to understand the flow of cement where it is going. That is the reason dye should not be given. Even if you are giving dye, dye should be properly flushed out before injecting the cement. Otherwise, don't give dye. It is preferable not to give dye. But other important aspect of it, that your cement, what is the cause of death in vertebroplasty? One of the complications of the vertebroplasty is death. Heart embolism. So fat embolism and cement embolism. These are the two reasons of the death in the vertebroplasty. So fat embolism is rare in the vertebroplasty. Fat embolism is more common in the kyphoplasty. So in the kyphoplasty and vertebroplasty, what is the difference? Almost same. So you are putting the needle there, and through that you are passing a balloon, inflating that balloon, creating the space, then taking the balloon out and filling the cement there. But in the process of you are creating the space there, you are inflating the balloon. So that time the fat, because vertebral body is a lot of fat, the bone marrow, fat is there. So fat embolism possibility increases. So that is the reason why kyphoplasty and vertebroplasty, fat embolism is commoner in kyphoplasty compared to that other vertebroplasty. Vertebroplasty you are not inflating any balloon, anything, so chances of the fat embolism is less. But cement embolism is possible in either of the cases. In fact, cement embolism is commoner in the vertebroplasty compared to the kyphoplasty. So cement embolism normally it's related with the how thick is your cement. If your cement is thick, then the chances of embolism is less. If your cement is liquid, then it will be more chance. That means you have to have such kind of consistency where you will be able to inject it. If it is very thick, you won't be able to inject it. So you have to able to inject it, but again chances of embolism will be less. And we call it as a toothpaste consistency. So the initially cement will be liquid, so you have to wait till it is hardening a little bit and becoming a toothpaste consistency. Or another very simple thing, how do you always do it? So you take in a syringe in a cement and put it a drop. When it will be like a string, immediately start filling it. When it will be hanging like a string, up to that consistency, you just go and inject. Okay? So injecting dye is not mandatory to know whether you are in the vessel or not. Only thing is, if frank blood is coming through your needle, then don't go. Then you just push the needle a little bit or withdraw the needle a little bit so that you are not in the blood vessel. Otherwise, vertebral body has a very rich venous plexus, and many times the dye communicates with the blood vessels. But if it is a very thin blood vessel, dye might be going there, but cement don't go, because cement you have already made the consistency is thicker. Okay, dye because it is a very much fluid, liquid, so very small finer capillaries also taking the dye outside. So that is the reason, and that don't have any contraindication. It's not contraindicated even if the dye is basically coming in the, and it is very common. Earlier in my start of my career, I always used to give dye to avoid that there will be no embolism if you are not connection with the, but almost always I have seen the dye is basically, if you are doing in the live fluoro, you will be almost always seeing that the blood vessel is, it is anterior, the venous plexus, and within the spinal canal, venous plexus, there is some sort of communication is always there. But normally those fine communication, because the vertebral body is also having a very rich venous plexus. But normally this is not that dangerous if your cement consistency is not that too liquid. If you are making it a toothpaste consistency, so it will not happen and dye is not mandatory there. Okay, so now 4 to 6 ml of the cement to be given, and the patient should be observed for some time. Normally it is not a painful procedure. When you are puncturing the first, going into the cortex, periosteum is the most painful areas always, and that time you have to take care. Adequate local anesthetic assurance, normally this takes care of the pain. Or you can give mild sedation. I don't prefer sedation because many patients, after giving some sedations, they becomes not obeying the verbal commands. They become restless, they don't understand what we are talking, not interpreting what we are commanding. So that is one of the problem in some patients if you are giving some sedation. So many prefer sedation, but I personally don't prefer sedation. Some anxiolytic doses is okay, but sedative dose I have seen the patient stops following the verbal commands. But if you are giving adequate local anesthetic, particularly over the bone, over the periosteum, then normally it is well tolerated procedure. Okay, so ideally your cement should be crossing the midline. If the cement is not crossing the midline, not adequately filled, you should put another needle from the other pedicle and fill it. But if one needle, your cement is crossing the midline of the vertebral body, then that has to be understood by the AP view, not by the lateral view. Then you need not put another needle. So normally this is not an issue for the lumbar area and the lower thoracic areas. For the mid thoracic areas, because the vertebral body pedicles are a little more vertical, it gradually in the lumbar area it becomes more oblique. So when it is more oblique, automatically going through the pedicle you will be reaching almost to the center. But in the thoracic area, you may need to put another needle. And upper thoracic area, you have to go transpedicular only. Extrapedicular, sorry. What is the post-procedural advice? Patient should be observed for at least few hours to see that there is no severe complications. Particularly the pulmonary embolism is a very major complications. And if we are having any doubt that the cement has leaked into the canal, how is the doubt come? How doubt may come? If your cement has arrived in the posterior 1/3, your X-ray cannot tell whether you are outside the spinal canal or not. And here is what I have shown you there, that if you are coming the posterior because of this oval shape, so you from the lateral view, if you see that it is in the posterior 3rd or posterior 4th, then you should have an CT scan. CT scan can tell you that whether your cement has come to the spinal canal or not. If it is in the spinal canal, immediately call your spine surgeon to remove it. Immediate operation and removal of the cement is needed. Otherwise, patient might be landing up with paraplegia. So vertebroplasty is a dangerous procedure, though it's very rewarding procedure also because it gives immediate pain relief, but has lot of complication. Paraplegia, the hemiparesis, then death because of the pulmonary embolism. So all these are the complications. And minor complications, some pain, local muscle spasms, these are common. Those are not major issues. Infection is also a very major issue. So sometimes there are cements available which are mixed with antibiotic, and some people they mix antibiotic amikacin when they are preparing the cement itself. And as I told earlier, the pre-procedure and the post-procedure antibiotic is preferable, though not mandatory, but preferable. And again, same way, the mixing the cement with antibiotic is not mandatory, but preferable. So the cement, commercially available cement is there. The cement, basic composition of the cement is polymethyl methacrylate, PMMA, polymethyl methacrylate, and it can be available as a low viscosity cement or high viscosity ordinary cement. Ordinary cement means orthopedicians what they use is high viscosity cement, but for the vertebroplasty, we need a low viscosity cement. So low viscosity cement is commercially available from the market, and those are mixed with radio opaque dye. Normally the cement itself is radio opaque, but opacity is not that much, and particularly in osteoporosis, the contrast between the bone and the soft tissue is so minimal that unless the cement is mixed with some contrast, it is difficult to identify the path of the cement where it is leaking. That is why either you take a low viscosity cement which is already mixed up with some additional contrast agent, or otherwise you can take the cement, ordinary cement, and you can mix up with the dye. The best dye is your barium, that is what is barium sulfate. So that is what is recommendation. But sometimes barium, when it is not available, somebody mix up with the omnipaque also, but that is not the recommendations. But if you don't have the barium, then you can go ahead with that. Nowadays availability of the barium is difficult, but the commercially available low viscosity cement is already mixed up with the barium, so you need not worry about it. That is the reason why it is better to have those cement, but it is more costly. Those cement are much more costly, almost 5 times more costly than the ordinary cement. So ordinary cement you can make it with the dye, additional dye, barium or your omnipaque, and you can give it. And you can liquid and powder part also you can alter a little bit to make it less viscous. Means powder part you can mix it less to make it low viscosity cement. But again, it needs more experience to prepare all those kind of things. Initially beginners should think of using the commercially available low viscosity with contrast. So post-procedural, you have to observe immediate complications are pulmonary embolism is the most dreadful complication. Apart from that, there might be the allergic reaction to the dye, to the cement, so you have to take care of that. You have to check for the neuro deficits. If the cement is leaked and there is neuro deficits, so you have to observe at least for the 6 hours after the procedure, and time to time check the neurological examination. If there is any problem anytime, immediately you have to contact your neurosurgeon friend, as well as you should have an MRI or CT scan to see how much bone cement has leaked. So if you have any doubt, how to understand the doubt? These are the doubts. One is cement is coming the posterior third, or there is development of some neuro deficits. Immediately you should have a CT scan or MRI. And if you are having some respiratory difficulty, these questions also I have seen in many of this multiple choice question, that you have done a vertebroplasty and patient has sent to the postoperative ward. After 10-15 minutes, patient has developed the respiratory difficulty. So what should you think? So you should think of pulmonary embolism. So immediately you should have an CT scan to understand if there is anything there, and you have to take care of that patient nicely. So immediate complications and late complications, there might be some hemorrhage also at the site of the where you have done. So that hemorrhage or cement itself might be coming into the spinal canal. You might not be getting any adequate the signs to doubt that there is some leakage of the cement inside the canal or hematoma, but that might be developing after some time, and that is the reason why this patient must be observed for at least 6 hours, if not more. And if the patient is discharged, then also you have to take the patient that if there is any neurodeficits, any weakness, any bladder bowel problem, retention of the urines, immediately. Retention of the urine is also a very important sign for the acute canal stenosis or cauda syndrome. So immediately patient should be reporting us if the patient is unable to pass urine. So these are the immediate complications. Late complications are basically infection. So infections to be controlled properly, and prevention is better than treatment. So you have to take care that the antibiotic and all other things, that infection is not there. Vertebroplasty is a very rewarding procedure. Immediately pain relief will be there. But again, vertebroplasty should be thought only when you people are expert in the basic procedures. Then only you should be thinking of the vertebroplasty. I know people in India, in Kolkata, vertebroplasty, after vertebroplasty landed up with paraplegia. So be very cautious before thinking it.